All right. Streaming, I'll just pop to Facebook and make sure. There we are. Lovely, lovely. We are off. People are entering the room already, which I love to see. Let's not keep them waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Neuroendocrine Cancer Foundation program. My name is Rain Bennett. I am your host this episode and every episode, and I'm actually a filmmaker and a writer by trade, but I've been working alongside or with NCF and Carcinoid Cancer Foundation as well for many years, over 10 years, which is wild to grasp, to swallow. But in that time, in that decade plus, we have created so many videos I've lost count, all different kinds of videos, live Q&A sessions like the one you'll watch today, patient-centric documentaries, event conference videos, treatment-based videos, all kinds of videos, but all with one singular mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here to do. Now, if you're new to this journey or new to this show, first of all, I want to say welcome, and the value that you will receive from this show that I have seen for 5 years now that we've been running the show is twofold. One, absolutely information and hopefully answers to some of your questions that you will get from our guests today. And two, the shared experiences and shared stories from within the community that I just alluded to, the people that are here every week or every other week, as it were, this year. So you might see people in the comment section already chiming in and saying hello, saying where they're signing on from. Do the same. I encourage you. First of all, a little selfishly, I love to see how far the programs reach. And so inevitably every week we've got somebody from some far corner of the earth that's still tuning in live, even though they're not in the Eastern or Central time zone where it's necessarily easy. So that says a lot about the show. But also you might meet someone in your neck of the woods, especially if you're in a place that's not necessarily near a net specialty center and you might need a little more guidance. A lot of the guidance that people receive in navigating this journey through this show is from within the community. So embrace the community. I ensure you they will embrace you back. It's something very, very powerful that I've had the fortune to witness over the years. Now, for this show, I'm excited to welcome back someone who has been here for many years in the past and whom I have worked with many times, Dr. Robert Ramirez. Dr. Ramirez, how are you?
I'm good, Rain. Great to see you. Great to be back.
Absolutely. We've known each other now for many years, and we were talking earlier about when we had seen each other in person, and I think it was right after it was right after the peak of COVID, because I traveled down to New Orleans and there was 0 people on Bourbon Street. It was something I'll never forget. I was in front of Jackson Square. I took a picture and there's literally not a single tourist in the photo. And I'm like, this is a little strange, but yeah, many years we've been working together.
Sure.
So for those that might not know you and the work that you do or the role that you fill in this net community I just alluded to, tell us where you work, what you do, and how they might be able to best pick your brain today.
Yeah, so I'm a medical oncologist. I'm at Vanderbilt University Medical Center in Nashville. I've been here for about 4.5 years or so, and prior to that was at the Neuroendocrine tumor program in New Orleans for a long time. And so I am a medical oncologist, see patients with neuroendocrine tumors and thoracic malignancies. Majority of my practice is neuroendocrine tumors. I lead the neuroendocrine tumor program here at Vanderbilt, and we've got a very good a very good team behind me, other oncologists, surgeons, gastroenterologists, nuke med. We do a lot of research, including clinical trials. So happy to talk about any of that.
Sounds good. Okay, folks, before we officially get started, just a few rules of engagement. First of all, before we move any further, I want to thank our sponsors, our presenting sponsors. We absolutely could not do the show without their support. And as I said earlier, we have been running the show for over 5 years now, going on 5.5 years, which is wild, but something that I am very grateful for this opportunity. I'm very fulfilled by. And of course, without your presence, we wouldn't be able to continue this show either. So I say this every show. For those of you who are regulars, you probably know where we're going. But for those that are new, it's hard in this format to, you can go ahead and start sending in your questions, by the way, because we're going to do our best to try to get to all of them. It's 60 minutes flat. It does move along pretty quickly. The best way to get your questions answered is short, generic chunks. It's very hard in this format to answer super dense, super case specific questions. There's no limit to how many questions you can ask. So you can always do it like a trail of breadcrumbs. Like, what's the first thing, the first domino that I need to knock down and get answered, which leads to the second. So you can always chime back in. If Dr. Ramirez needs some more information or clarification from you, we'll ask and you can chime back in. But oftentimes if you're just kind of dumping every single, specific thing about your case into the question, it's just hard to address in this format. So otherwise, send in your questions. We'll try our best to get them all. And as I said earlier, a lot of times the answers or the help that you're looking for comes from people within the community. So for everybody watching, you can feel free to chime in with your thoughts too about a certain experience or a certain question. And if anyone here that is usually here and you haven't seen them sign in yet and say hello, you can always tag them in the comments, share this video with them. We are simulcasting to Facebook and YouTube. So we have a little bit more reach now, and that YouTube audience is growing every day or every week. So we love to see that. So go ahead and start sending in your questions. Shout out to everybody. Special shout out to Dave, who's in Durham, North Carolina, right down the road from me. Hello. We also had Dr. Diane Reedy on here not too long ago, who is now at Duke. So Durham's coming up in the world. Just kidding. We've always been awesome. First question comes from me, Dr. Ramirez. We were kind of talking about your team there at Vandy. And we often touch on this topic of the team, right? In the net space, and why multiple members from multiple backgrounds are important for that team. What makes up a good team, in your opinion? What are the pieces? Who are the pieces that you really need for a quality multidisciplinary team in this disease?
Yeah, thanks for that. It's so important to have a team. Working with a dedicated group of professionals every week is really it really moves this field forward. It moves the patient journey forward. And it's nice to be able to meet with folks every week, and usually every day. I talk to members of my team about various things regarding patient care, research that we're doing, future research projects, and not just my team doesn't just. It's not limited to Vanderbilt. I work with people, from multiple other institutions as well on various projects. So we're always doing something. I think it's you alluded to how we've known each other for some time. This show was you said for 5 years, but you were doing something else before that, right? With us, right?
We did have a prototype, so to speak, in 2019. We started a Facebook Live show. That's correct. And then when the pandemic hit in 2020, I wasn't out doing like the documentaries and such, at least for a good 6 to 9 months. And so that's when this idea, like, well, what if we did this? Yeah, this weekly show. So yes, that's accurate.
Yeah. So where I go with that is, I'm getting further into my career, and at some point, I may drop off the face of the earth.
Please don't.
But it's up to me to also train the people, the younger physicians and who are coming behind me, and making sure that this group of patients has good doctors to go to.
Yeah.
So we meet every week. We have our tumor board meetings every Wednesday, very well attended. They've been over Zoom for ever since the pandemic until earlier this month. We held our first in-person tumor board, and it was wonderful because I got to meet people who I talk to all the time, but had never met in person before, and so it's nice to come back to that. So tumor board every week, we discuss our patients. We have our monthly research meeting with our team and discuss upcoming projects. And so it's really it really is a team approach.
Absolutely. Yeah, to that point, that made me think of when you're talking about kind of, you didn't say ushering in the next class, but passing it down, paying it forward. Another thing I do for folks at home, I mentioned this is these patient-centric documentaries, and this is somewhat of an announcement, but we don't really have a firm announcement yet. But some of I've been working on a bigger piece for CCF, feature film about the strength of this community, the NET community. And so, anyways, I was in West Virginia just yesterday, interviewing a patient and talking about that concept. And I think it's a really beautiful thing about this community of she was basically talking about how doctors in different parts of the country were collaborating on her case. And that's something she said, these words, that there's really not a lot of ego with a lot of the doctors in this space. And I think that's such a beautiful thing. And you were kind of touching on that, Dr. Ramirez, just that we work together is basically what you were saying, but it reminded me of what she had echoed, a bit of just like, and I think that's a really important part of this, is that there is no ego and people are willing to share. We're really trying to get to the issue at hand and not take the glory from it, but rather get to the answer.
Yeah, I think that's really important. I actually just saw a patient on hospital rounds today who has a neuroendocrine carcinoma who wanted to get another opinion at MD Anderson. I said, well, who are you seeing? You should see Arvind Dasari down there, or James Yao, and maybe they have something more for you, or so yeah, we'll send people. We collaborate with people from around the country. We'll if I've because other people may have things we don't have. The clinical trials are very site specific in many cases, and so if I know of a trial across the country and my patient is willing to travel, I'll make a phone call and say to my colleague, hey, can you get this patient in for your trial? So yeah, and so we all work well together.
Absolutely. Well, we got some questions coming in, so let's not keep the people waiting any longer. I could probably talk to you the whole hour myself, my friend. This first question is maybe not necessarily aligned with your specialty or your expertise, but it's an important question. So it'll give us an opportunity to talk about these concepts at least. So Jim says, I believe that mental positivity is a huge key in navigating the cancer management journey. I'm always trying to find wellness options that will benefit me mentally and physically from a self-care perspective, as the tendency is to focus on the cancer, only focus rather on the cancer and related treatments. One constant concern for me is unknown potential impacts of different types of treatments on my disease progression. Is there a resource that you're aware of that people can go to determine potential risks of things such as infrared sauna sessions, red light therapy, acupuncture, etc.? Is there any trusted and established research being done in this area?
Yeah, this is a great question. We get questions like this all the time, and I think
for sure.
I think the issue is there's not a whole lot of data, clinical trial evidence to say this may or may not be beneficial. I tell my patients I'm not opposed to anything. If you think this is making you feel better, by all means, I think it's a good idea. I don't know of a central resource to say this is how we navigate these alternative therapies, and then also how do they interact with what I'm doing. That's always my concern, especially when it comes down to some of the medications that we may want to try. I think things like exercise and acupuncture. I mean, I think these are all very well established techniques, and they're beneficial for patients. Sometimes when we think about some of the other therapies, maybe not as much data behind them, but again, I don't think there's much harm in that.
Got it. Thank you, Jim. And this is for folks at home listening. This is also a good opportunity of a place to share your experiences. So talking with someone like Jim and say, like, yeah, I tried this and it helped. Also remembering that we're all different and each case of this disease is different. So my approach, I'm not a medical expert, but my personal approach is when trying something new like that is in trial and error is, a little bit at a time, see how it plays. But yeah, I do think it's a good thing to consider for sure. Next question. Oh, this is just a comment actually from Edie. Just wanted to say thanks so much for training Dr. Daniel Freno. He did my lobectomy 2 years ago. Blessing. He's a blessing from the Lord. So just a shout out on that one. From Mara, how many sessions of PRRT for infusions is safe to do?
The questions, is 4 sessions of PRRT safe?
Yes, I have my own hunch of what the question is being asked, because 4 cycles is the normal. Correct. Right. And so I don't know if the question is like how many of those can we have, but I know that's something that's being discussed right now. And Mara, you can feel free to chime in and clarify if you want to. Do you feel like you can address that,
Yeah,
Dr.
the
Ramirez?
standard treatment for what we have that is FDA approved is lutetium dotatate, or the brand name is Lutathera. This is given over a series of 4 infusions every 8 weeks. So that's sort of the standard. Other clinical trials that are coming along using actinium or lead products, it's similar. There's another trial that I've learned of recently that's doing it every 6 weeks. So I think it's going to vary per product. Now, usually after those 4 cycles, we assess how patients did on them, if disease is stable or responding, the patient's doing well. Then we sometimes will continue on with maintenance somatostatin analog. Sometimes we don't. Sometimes we hold treatment altogether and just monitor the patient. Now, when it comes down to if disease is growing and it is felt that maybe additional PRRT is indicated, that's where it gets a little muddy about whether or not an additional 4 cycles is beneficial. So we tend to do that. Here, there's a lot of retrospective data saying that it's safe and effective, does not put you at a higher risk of complications due to bone marrow toxicity. There's actually a clinical trial right now open called the NET Retreat study. This is led by Dr. Chauhan and Dr. Singh. And it's actually randomizing patients to either a standard of care everolimus versus an additional 2 cycles of PRRT. So we'll get to know in a prospective fashion just if things are safe or not. We tend to do it. We don't think much about it. As long as people have gotten a good response, we can go back a year later, or a year and a half, or 2 years later and give a second course.
Got it. Thank you. And thanks for your question. Here's one that is right down your alley. From Denise, I have DIPNECH. What advances have been made in surveillance, and how often should I be checked long term?
Yeah, so DIPNECH is a pre-malignant condition that mainly affects females in middle age. We don't know what causes this. They tend to present either with symptoms of cough, trouble with breathing. Sometimes they present with incidentally. I had a patient just a few weeks ago came in for abdominal pain because of a kidney stone and picked up a nodule in the lungs, and that led to this diagnosis. And so usually, so I say it's pre-malignant because we think this can turn into pulmonary carcinoid tumors. Now, the pulmonary carcinoid tumors, there's very established guidelines for what to do with these as you take them out. But these folks sometimes have multiple primary carcinoid tumors. So you see the lung is valuable real estate, so you can't go and take all of these things out. So a lot of times we will try either somatostatin analogs or sometimes even just observation with patients, because we don't, if they're not symptomatic, we may not necessarily need to do anything. What the gray zone is some patients have DIPNECH, and without evidence of progression to pulmonary carcinoid tumors. Other patients have pulmonary carcinoid tumors without evidence of DIPNECH, and then we have people in between. So that's what we're trying to sort out. Now, when it comes down to surveillance strategies, so you have a diagnosis of this. Are we on treatment? Are we not on treatment? Usually, I can get away, and patients can get away with a CT scan of the chest yearly. Unless there's newer symptoms, worsening symptoms that develop, I'll tend to check pulmonary function testing, usually on a yearly basis or every other year basis as well. And as long as there's things remain stable, we may not need to do anything. We just continue to monitor. It's when things start growing, symptoms start developing, then we start to think about this. And part of my team, as I mentioned earlier, is actually the pulmonologist. So my pulmonary team is really important for my DIPNECH patients to see as well, because sometimes they have other treatments outside of the somatostatin analogs, which may be beneficial.
Got it. Thank you. Appreciate your question, Denise. From Mara again about PRRT. How long does it take for platelets to recover after PRRT? I had to stop after the third one because the platelets were at 65,000.
Yeah, this is one of the known side effects of this. Some of it's tough. Sometimes it takes a long time to recover, and there's many cases where patients aren't able to complete that fourth cycle. Doesn't mean that that you don't get a response from your first 2 or 3 cycles. You just may not be a candidate to move forward. So usually we'll watch up to 16 weeks or so before we say it's not safe to give this anymore. And there's a lot of factors that can play into whether or not you're at a higher risk for developing that prolonged thrombocytopenia or low platelets. And many times I'll have to get my patients over to my hematology colleagues to kind of help out and see if we need to be doing anything else.
Gotcha. Thank you, Maura. From Amy. Amy says, I just had a left upper lobectomy for a NET and 1 positive lymph node. My tumor board is recommending no further treatment. Should I find a NET specialist?
I'll never disagree with finding a NET specialist, but usually in patients with typical and even atypical carcinoid tumors of the lung, after they've had resection, even if they're stage 2 or stage 3, there's really no role for adjuvant treatment that we know of. Adjuvant meaning chemotherapy or anything else after surgery. So in many other types of cancers, including non-small cell lung cancer, if you, in that same situation that was described, a tumor taken out and this the lymph node is positive, we're usually giving chemotherapy and likely immunotherapy afterwards for a finite period of time to try to kill off any micrometastatic disease. But the reason we do that is because we have very established clinical trials that show that this is beneficial. We do not have that with the pulmonary carcinoid tumors. In fact, we have data to suggest just the opposite, that sometimes people who go on to get adjuvant treatment actually do worse.
Gotcha. Thank you, Amy. Ruby says, my pancreas stopped producing digestive enzymes and now has stopped producing insulin. What other adverse effects could I expect from somatostatin?
Yeah, this is a at least the pancreatic digestive enzymes. This is a well-known side effect of the somatostatin analogs, and sometimes Sometimes we put people on replacement digestive enzymes, things like Creon or Zenpep, which can sometimes be beneficial. Sometimes people can't tolerate treatment. If we're running into issues with hypoglycemia, I take people off. If it's strictly pancreatic insufficiency, digestive enzymes, I can use my enzyme supplementation. If people are running into, one of the other side effects is hyperglycemia or high blood sugars. I work with my endocrine docs, and we come up with a regimen for that. But if it's severe, again, I'll there's many patients can't tolerate it, and I take them off.
Gotcha. Next question from Denise: are there any treatments being performed currently elsewhere in the world that we're not doing in the U.S.? I know historically we have seen
sure. Yeah, the answer is yes. and now, even I think in many cases, sometimes we're slower to get some of the newer technology. So, for instance, even PRRT. This was approved, Lutathera was approved in January of 2018. So it's been around for a long time, but it's been around even longer because, we used to, when I was in New Orleans, if patients had the means, we would send people to Switzerland to go get this treatment because they were doing it over there. They do things, and they do a lot of different radionuclide treatments in India, these kind of things. So it's, but I think some of it has to do with regulations and whether or not, you're going to be eligible for clinical trials. Sometimes these other sites do these things off of clinical trials. So yeah, there's a lot of different, different things to explore. Some of the, like for instance, some of the alpha emitters we may talk about, you can go and get these things off of protocol elsewhere in the world. Whereas, at our institution, we have very strict criteria for clinical trial enrollment. And so yeah, I think if you look hard enough, you'll be able to find things elsewhere.
Absolutely. Thanks for your question, folks. If you joined us a little bit late, this is Luncheon with the Experts, a Neuroendocrine Cancer Foundation program. We are here today with Dr. Robert Ramirez from Vanderbilt. And somebody says, Jim says, I've been in Dr. Ramirez's care since his beat one at Vanderbilt. I'm thrilled he is part of my 15-year journey with NETS. I'm still here with no need to stop now. Thank you for all you have done for me. Jim, I appreciate that sentiment so much. Thanks for sharing, my friend. Vicky says, I'm a newly diagnosed NET patient since October of 2024. Even with the removal of the tumors in my stomach and lung, I still do not feel myself. I have no energy. I have asked my doctor if there's a certain diet that I need to follow. Again, this is a topic worth talking about. Might not exactly be your specialty, but what are your thoughts for Vicky?
Yeah, it sort of depends on what's happening. Fatigue can come along with this disease.
Yeah,
but fatigue is also not exclusive to this disease. So there's a lot of things that can be related to fatigue. So I think exercise is important for this. Depending on what kind of medications we're on, sometimes we may need to make adjustments that way. Is the cancer controlled? In patients who have no evidence of disease, then I work with the primary doctors as well and try to sort out, all right, what else can we do here? So I think there's, it's really an individual approach.
Mm-hmm. Yeah, and this is, back to my initial point earlier in the conversation about just all the video content that we have created. Between CCF and NCF, there's a lot of content at your disposal for free in our library. And many of those deal with nutrition. So you can always use those as resources as well. And let us know if you have any trouble finding those. There's video libraries on both Facebook and YouTube that you can go through and should have some information that would help you. Next question comes from Larry. Larry says, I have a 20-year history of pulmonary hemosiderosis. Is that right? Hemosiderosis since long before my NET diagnosis. Surgery had addressed the initial tumors, but now showing up in the pancreas, liver, and hip with suspicious activity in the lungs. Dotatate, by many accounts, has limited clarity in lung tissues. Any thoughts on an approach to distinguish hemosiderosis from NETs?
Outside of tissue sampling, probably not. I think the dotatate PET CTs are they're very good in lung patients. Not all lung patients have somatostatin receptors, so that sort of limits that.
Got it. Thanks, Larry. Let me know if you have any other questions, my friend. Next question from Jennifer. Why is it that the lung net cells are more able to cross the blood-brain barrier and cause brain metastases than GEP nets are? And should lung primary patients ensure their dotatate scans start from the top of the head?
So, good question. I'll address the second one first. So the dotatate scans do go to the top of the head. So they will pick up things, and I don't necessarily see lots of brain metastases. I see them from time to time, but it's still an uncommon phenomena for a typical or even an atypical pulmonary carcinoid tumor to spread to the brain. I've seen it, but it's uncommon. The dotatate PETs go to the head. Usually, when I'm following people, I don't follow with MRIs of the brain at all. I'll follow with CTs of the chest, generally for 10 years after resection. Sometimes people can have late recurrences. Where I'm suspecting brain metastases would be if patients come in and say they have headaches or visual changes, or sometimes even unexplained nausea or vomiting that's prolonged. Certainly seizures. This is where I'm thinking, all right, let's get an MRI of the brain, because even if we have a dotatate PET, which is negative, which I alluded to before, sometimes the lung neuroendocrine tumors don't have those somatostatin receptors. So the MRI is really the best test.
Got it. Next question from Neom. Please let me know if I'm pronounced that correctly, and if not, how that is pronounced. The question is, are there any new studies being done on DIPNECH? We were talking about that a little bit earlier.
Yeah, so there's no prospective studies that I'm aware of yet. Now that said, we are creating our registry prospectively of patients seen here at Vanderbilt. We're over 80 patients now with this rare entity, and I'm looking to start a multi-institutional series with DIPNECH patients in hopes of starting a clinical trial on a certain compound that I've looked at and had some experience with. I won't go into it too much, but to say I'd like to, that's going to be the next step here.
Got it. Next question from Mimi. If a patient has Cushing acromegaly coming from nets and lungs, would the patient respond to lanreotide, or is it difficult to control the hormone levels compared to it coming from the pituitary?
So patients with, especially with lung neuroendocrine tumors, can produce ACTH, which can lead to Cushing's. Now, and I've seen this, and in fact, Rain, I think you had met one of my patients at this.
Absolutely.
Too, and she was a young woman who had this, who developed Cushing syndrome, and people couldn't figure it out. And then they saw this little thing in the lung and said, well, what is that? And ended up getting treated, and everything got better. So that's the treatment for this, is to try to get rid of tumors. Now, if this is something metastatic, that certainly becomes more problematic if we can't get rid of everything. But we try to, even in the GI net, sometimes if patients, tumors are secreting serotonin, we get rid of those big tumors in the liver, for instance, and that'll bring that serotonin level down. That'll help with their symptoms. So the ACTH producing tumors within the lung, if we can get rid of those, that will generally help out. If not, we use things like lanreotide or Lutathera. I work with my endocrinology folks as well, and they certainly help out.
Got it. Thanks, Mimi. Next question from Valerie. My friend would like to be seen at an out-of-network net specialty team, but is being fast-tracked to a thoracic surgeon for removal of a recently diagnosed lung net. She would like to be monitored by an integrated net specialty team, but is finding that access pre-surgery is being denied. How do we think he or she should proceed?
It depends on the institution, I guess. I think here at Vanderbilt, we work with our thoracic surgeons. The bottom line is that the thoracic surgery team, if a resection is indicated, that's what they do. And remember that pulmonary carcinoid tumors are only 2% of all lung cancers. So a carcinoid tumor specialist thoracic surgeon that only does pulmonary carcinoid tumors doesn't exist, as far as I know. But we work with them, and they're all, what I always tell patients is, find a surgeon you're comfortable with that specializes in lung cancer surgery, and they will generally do a good job. Now, when it comes down to surveillance, usually when my surgeons, if they see someone initially, sometimes they'll send them to me to start out with, or if they operate on somebody, they'll send to me afterwards for ongoing surveillance. So I think either approach is fine. I think either, just talk with the surgeons and say, who do you recommend moving forward, and can I get in touch with your net specialty team if there's one there, or elsewhere. And certainly I'm happy to, I certainly see this patient population where patients get operated on elsewhere and then come to me, for ongoing surveillance.
Gotcha. Thanks for your question. Next one comes from Ashley. Ashley says, I was diagnosed during pregnancy with a typical carcinoid lung tumor in the main bronchus. Pathology was PT1A and O. No mitotic figures identified, no necrosis, but Ki67 was 11.1%, and it also said lymphatic invasion was present. Do you think this could behave more atypical because of the high Ki67?
It's possible. So the grading for lung net tumors is a little bit different than the GI tumors. And up until recently, we didn't really use Ki67. We used mitotic index, presence or absence of necrosis, and that broke them patients into either typical or atypical carcinoid tumors. Now there's a newer entity that uses Ki67, but usually this is a much higher, so about 30%, where we say this is an atypical carcinoid tumor with an elevated mitotic index or Ki67. So, and the question was an endobronchial tumor. Is that did I hear that correctly?
Typical carcinoid lung tumor in the main bronchus.
Yeah. And so with that, that's a sort of a special entity here, because sometimes what we can do is actual what we call endobronchial therapy, and we do this with various procedures where if that tumor is stuck there in the airway but is not elsewhere, sometimes we can avoid an actual surgery by going in through a bronchoscope and either freezing the tumor or cooking the tumor, but essentially killing this tumor off, taking it all out. That doesn't mean that we can't do surgery in the future if we need to, but that's just one of the strategies we use.
Got it. Thank you. Appreciate your question, Ashley. Next one from Dave. Hey, Dave, do you know of any post-resection tests like Signatera for NETs? As far as I know, Signatera no longer tests for NETs. I know the so-called NET test, but that seems less reliable. My typical grade 1 RLL lung NET had venous invasion and was present in 4 lymph nodes, including one of the subcarinal mediastinal nodes, so we are concerned about recurrence.
Yeah. Unfortunately, we don't have any. Signatera is not specific for neuroendocrine tumors. So in fact, I don't think I've ever ordered it. It's I know some of my GI colleagues, they'll order it for monitoring their patients, but not specifically for NET. I usually follow with scans and symptoms.
Got it. Thanks, Dave. From Sandra, what's the outlook for alpha PRRT?
Great question. I think the early data on alpha looks really good. I think we're always trying to push the bar to advance the field. In thus far, the data on alpha looks really good. In the U.S., there's 2 trials. Actually, one trial actually just wrapped up. So this was the Action 1 study that took patients with who had seen Lutathera in the past, and after a period of time, if they had progressive disease, then they randomized them to either the alpha treatment using actinium-225 versus standard of care. And what we had a choice of what we could use for standard of care. Patients who were randomized to the standard of care, if they progressed on that, then they would switch over and get the actinium. So that study is a worldwide study that actually just closed to enrollment last month. So it'll take some time for it to read out, but I can tell you, patients that I had on it were, they did really, really well. I've got one patient still getting it. So I think time will tell. There's the other alpha emitters like lead-212. There's a few different companies that are doing those, and I think I think alpha is going to be the future. So there's other trials that I have in startup now using lead or even actinium, and there's even one of my trials is actually using an alpha emitter without using amino acid infusion beforehand. So that's going to cut 4 hours off of that dosing. So I think the future's bright. So stay tuned.
Nice. All right. Appreciate that, Sandra. Next question from Mimi. Why would my lung net light up on a DOTATOC PET scan but not DOTA-TATE?
Unclear. I think I think I'd be trying to look at those scans myself and seeing how much, lighting up is very subjective. We look for things like standard uptake values and things like that. So it's sometimes in the eye of the radiologist as far as what actually lights up. Gotcha.
Thanks, Mimi. Let me know if you have another question from Harriet. Hey, Harriet. How many years should you have a follow-up after a lobectomy with diagnosis of typical neuroendocrine cancer of the lung?
Yeah, usually I'll follow people with CT scans of the chest at 6-month intervals for 2 years, and then I space it out to yearly for 10 years.
Got it. Thank you, Harriet. From Alyssa, should someone with functional NETs/gastrinomas discontinue somatostatin analogs monthly injections following 4 rounds of PRRT?
So somewhat of a area in flux. I think it sort of depends on. Usually, we will continue the somatostatin analogs for functional tumors. If it's a non-functional tumor in patients who've progressed on it, that's sort of one of those things where I say, all right, well, if you progressed on this, do we really need to continue this or not? But certainly for functional tumors, I'll usually continue.
Mm-hmm. Got it. Thank you, folks. We've got just shy of 15 minutes left. We're going to keep plugging along, try to get to as many of these as we can. Appreciate you for being here. Nice numbers today. Must have a special guest. Wink. Next question from Tom. If you had a patient with CKD, chronic kidney disease, stage 4, would you be inclined to do an MRI or a PET dotatate for liver disease?
So it's sort of, stage 4 CKD. If I can get so the imaging, the MRI is the best test for the liver. Okay. So we try to do this with contrast. The issue with patients with CKD, there's a rare complication that they can run into. And so sometimes the radiologists don't like to do the MRIs. But if we can, again, it's a rare complication that happens here. So, and I think even nowadays, some of the contrast they're using, we're not even worried about it. But certainly MRI if possible. If not, dotatate PET. Usually for other patients, if I'm not thinking about an MRI, if I'm thinking about someone with chest who needs chest imaging or small bowel imaging, bone imaging, instead of a contrasted CT, we do dotatates.
Gotcha. Let's see. Appreciate your question, Tom. Good to see you, my friend. From Sean, does an MRI help show lung tumors?
No. Best test for lung is CT.
Got it. From Christy, what are your thoughts on trying, and I'm not sure for what, so Christy, you might need to let me know, but the question is, what are your thoughts on trying ivermectin or fenbendazole, rather?
Well, I get this question a lot. There's a lot of uncertainty about some of these medications, and so I don't know how this works in patients with neuroendocrine tumors. I can tell you there are no studies that tell us this is beneficial for patients with neuroendocrine tumors. It may be safe and effective, but I've got no data to support its use, and I don't recommend it.
Copy that. Thanks for your question, Christy. From Valerie, is there a defined standard of care protocol after surgery for a lung net that does not yet to appear to have metastasized? And if so, like how many years, what type of imaging, for how long, identification of biomarkers desirable pre-surgery?
Yeah. So usually when I see a new patient with a lung net that's surgically resectable, I'll tend to get a dotatate PET on them. One, to tell us, do they have the receptors on their primary tumor? And that's something that it doesn't change what we do up front, but it helps sometimes monitoring in the future. So a dotatate PET, and sometimes it'll show lymph node metastases as well. So it'll give us an extent. Sometimes it'll tell us distant metastasis. After surgery, then what I do, if I've already got that dotatate PET, then I will, like I said, follow with CTs. If they haven't had a dotatate PET in the past, they come to me afterwards, and maybe there's some lymph node enlargement or something questionable. Then I'll get a dotatate PET at that time, and then like I mentioned, there's then this CT protocol for 10 years. If I'm 5 years in and now there's a new nodule that pops up in the lung or enlargement of a lymph node, then I'll switch to a dotatate. I don't have any good biomarkers that I follow people with, unless, like we had mentioned earlier, in those patients with the ACTH producing tumors. Occasionally there'll be a serotonin producing tumor as well. So these are things that we can follow, over time. But usually I don't follow with the biomarkers, just with scans and patient exam and symptoms.
Gotcha. Thank you. Next question from Tanya. As a patient who recently had a debulking surgery of stage 4 metastatic NET, who had been treated with morphine for extreme joint pain from carcinoid syndrome, and the pain has returned, is that possible? Is it possible I still have tumors that were unable to be removed at debulking?
I think that could be a possibility. You'd have to check with your doc, and probably need some new imaging and exam and kind of sort out what's happening.
Yeah. Tanya, let me know if I got all that question right, or if you have a follow-up question. We're still here for about 9 more minutes. From Mimi, have you ever treated a patient with thymic NET? Is it possible to have both thymic NET and lung NETs?
Yeah, I have. It's the thymic NETs are pretty uncommon, but you see them from time to time. I don't know if I've ever seen thymic and lung at the same time, but it's certainly possible. If it's a primary lung NET and a primary thymic NET, I would be thinking about some genetic testing as well to see if there's any inheritable mutations. Sometimes people with MEN1 can have an increased risk of foregut tumors, which include the lung and thymus, stomach, pancreas. So these are things that I'd be watching out for.
And follow up from Mimi, can NETs secrete histamine, and what would be the symptoms, and can you test for it?
They can, and you can test for this. So sometimes wheezing, cough, rash, these are things that can come along with this, and you can check a histamine level. That can vary. If it's less than twofold increase, I don't really worry about it. It's when those patients are much higher, then I say, well, maybe something's happening and this tumor is really secreting histamine.
Thanks, Mimi. Appreciate you being here. I think it might be your first time, so welcome. From Crystal, can you lean toward ruling out NETs if a new lesion found on the pancreas only lit up in the venous phase of 3-phase pancreatic protocol CT? This is 6 months after a grade 1 tumor was resected from the small bowel.
So I think the best way to rule it out is to biopsy it. There's other things that can happen in the pancreas, other benign processes. So it's really hard to tell. I think usually if I see something like that, I'm thinking I take it to my tumor board. We get a pancreas specific CT or an MRI, and then if it's suspicious, we will do something called an endoscopic ultrasound or an EUS, where they can actually visualize the tumor through ultrasound and do a biopsy.
Got it. Thank you. Speaking of MEN type 1, Jesse says, is it possible to have more than one genetic disorder? I've been diagnosed with MEN type 1, but I have tumors in my parathyroid, pancreas, lungs, and adrenal glands.
Mm-hmm. Well, that goes along with MEN1. foregut tumors, so pancreas, lung, hyperparathyroidism. Adrenals are a little different. So, certainly adrenal tumors can be a metastatic process if that's truly the case. Sometimes adrenal tumors are benign, so that we call them adrenal adenomas. So sometimes it's a little bit hard to sort that out. But yeah, you can certainly have more than one thing.
We've touched a lot on scans, but Jan had a question that just said, which is better to see tumors, the dotatate PET scan or the CT scan?
It sort of depends. Usually the CT is the best thing to follow with. Now, occasionally, if patients have multiple small things, mainly within the bone, where I'm not going to be able to see everything on a CT, I'll get a PET. But I usually don't follow with PETs, and the reason being is there's a lot of noise that comes along with PET, meaning things light up, but they may or may not be related to the malignancy. What I'm looking for on a CT is actual growth. So for instance, I may have a lymph node which lights up on a PET, will continue to light up, and unless it grows, I'm probably not going to do anything different. Now, you may, and one of the questions I get all the time is about how bright these things light up. So on the report, when you read the report, they'll say 1.2 centimeter lymph node in the mediastinum was dotatate avid SUV 5, previously SUV 3. Now that you may look at that report and say, oh wow, my cancer is growing because the SUV is 5 and before it was 3. Well, that minimal amount of change, and even if it was higher, that doesn't mean much of anything as far as progression. That level can vary, and so what I'm looking for is there actually any changes in size on this? So that's why I tend to follow with CTs, because we can see those smaller things much better on the CT, the actual anatomic imaging.
From Pat, hey Pat, can lung nets metastasize to the thyroid?
It'd be uncommon, but I think they can go anywhere. I think the best thing at that point is, a lot of people have thyroid nodules. Best thing is an ultrasound and then a fine needle aspiration.
Thanks, Pat. From Amy, speaking of genetic testing, should all NET patients be genetic tested?
So it's a minority of patients who have a genetic syndrome that puts you at a higher risk. So patients that I'm thinking about doing any genetic testing to look for an inheritable gene, those patients who have multiple primary tumors, certainly those patients who have a family history of this. If there's other features, if I have a patient who comes in with a calcium which is really elevated and find out they have abnormalities of the parathyroid, well, that goes along with MEN1. So I think I'm not testing everyone, but people who are suspicious enough with those factors. Sometimes some of my younger patients as well, we'll do that as well.
Gotcha. Well, we are here at the 60-minute mark. Robin says, great show. Thank you, Dr. Ramirez, for your matter-of-fact responses. Andrea says, thanks for your time, Dr. Ramirez, our favorite doctor, singing his praises. I tend to agree. You're one of my favorites, my friend. Thank you so much for being here, Dr. Ramirez. Appreciate your time today.
Absolutely. Happy to be here. Looking forward to seeing you at NANETS next week.
Yeah, we're going to see each other in person, which we haven't in years since that trip to New Orleans, I think. And folks, for you all at home, appreciate you being here as always. I hope this program helped answer some of your questions. One quick note, if you have questions in between our next show, which will be 2 weeks from now, you can always reach out to ncf.net/support line and get your questions answered there, or the direction to the people who can answer those questions. So we appreciate you very much. Thanks again to our presenting sponsors. Finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.